Hello, everyone. Thank you so much for joining us for the launch of this symposium today around the issue of what must be done to prepare for our next pandemic. I'm really excited to launch these sessions with this session that's really focused on global lessons learned and really reflecting on how the COVID-19 pandemic will shape future pandemic responses, and to do so with a global perspective from the experts that we have gathered today. My name is Dr. Rachel Vreeman. I'm a pediatrician and I'm the chair of the Department of Global Health at the Icahn School of Medicine at Mount Sinai. I'm also the director of the Arnhold Institute for Global Health at Mount Sinai. And here we are together. So we are a year into the COVID-19 pandemic, and we're trying with this time that we've set aside to reflect, but to reflect in an effort to help us look forward and really address this question of not only gathering immediate lessons learned for what we need to do now, which is what we've been talking about throughout this year in these sessions, but also what must be done to prepare for the next pandemic. As much as we hate to think about it, we're very aware that we would be remiss if we didn't think towards the next pandemic. So with where we are right now with the COVID pandemic, of course, tragically, globally, more than 2 million people have lost their lives to this virus. In the United States, where most of us are sitting right now, we've had over 400,000 people die as well. The virus seems in many ways to be gaining steam. Of course, we're worried about more contagious new strains or variants of it. We're worried about greater spread. We continue to worry about our hospital system's capacity to meet the major needs that are there. And the current statistic is a terrible one, that every 7 minutes in the United States, a person is dying from COVID. At the same time, too, we also know that among those who've recovered, that we also see many individuals really struggling with long-term impact and long-term effects from the COVID disease that they've had. And we don't fully understand the long-term effects of the virus. I think it's fair to say, as we sit here, that this has been an experience that has changed all of us, even as we have a team of global experts, and as you'll hear, people with a lot of experience both in healthcare and infectious disease management, in coping with pandemics globally. And yet this is a really particular place that we find ourselves in as well. So for all of that, with all of this tragedy and all of this burden, we want to make sure that the field of global health improves as a result of everything we're going through, that we can learn from our lessons, that we can move forward, that we can actively move for change and for making things better. So I'm really delighted to have this group of global experts with us today to talk about just that challenge. Let me go through introductions here. So first, we have Dr. Madeleine Ballard. Dr. Ballard is the co-founder and the executive director of the Community Health Impact Coalition, which is a coalition that serves as a field catalyst to practitioners in more than 20 countries globally. And this coalition is focused strongly on making professionalized community health workers a norm worldwide, making that a standard. Dr. Ballard is also an assistant professor with us here at the Department of Global Health at the Icahn School of Medicine at Mount Sinai. She has a PhD in evaluation science from the University of Oxford, where she was a Rhodes Scholar. And before her executive director role with SHEIC, with the Community Health Impact Coalition, she was the founding program manager for Last Mile Health, which is a Liberian organization that recruits, trains, and equips community health workers to provide primary care in remote villages. We're also excited to welcome Dr. Joe Massey. Dr. Massey is a physician, an educator, and an author. He's based in New York City in Elmhurst, and he's also co-hosting today's seminar with me, which we of course appreciate. So we'll be hearing more from him as the sessions go on. Dr. Massey is a professor of medicine, and he's also a professor in the Department of Environmental Health and Public Health, as well as in the Department of Global Health with us at Mount Sinai. He served as the director director of the Department of Medicine at Elmhurst Hospital Center, which is New York City's Health and Hospital, Elmhurst Hospital, from 2002 through 2017. And then he became the chairman of the Department of Global Health at Elmhurst as well. Dr. Massey has extensive experience in taking care of patients with HIV, with TB, both through research, through clinical care, and through his writing and numerous projects. He's also worked a lot on disaster preparedness and the threats of bioterrorism. And he co-leads with another faculty from the Mount Sinai Department of Global Health, Dr. Sheila Maru, our partnership that we call Cure 19, a research unit focused collaboratively with Elmhurst and Queens hospitals on how to move forward COVID-focused research to really serve the needs of frontline providers in Elmhurst particularly. And then third, we have Dr. Adrian Gardner with us. Dr. Gardner is the Associate Dean for Global Health and the Director of the Indiana University Center for Global Health. He is an infectious disease physician who previously served for 7 years as the Executive Field Director for the AMPATH Consortium in Eldoret, Kenya, in Western Kenya, which for those of you who know me is also where my research work and clinical work has taken place for quite a number of years as well. His areas of interest and work include program development and health system strengthening, particularly for resource-limited settings. He does clinical and operational research in tuberculosis and HIV, and also has a lot of experience with growing up global health training and education programs, as well as his expertise in antimicrobial stewardship and infection control. During this pandemic, in addition to his global role with the AMPATH Consortium, Dr. Gardner has also become the director for the contact tracing efforts of the Indiana University Medical Response Team. So I'm really, again, thrilled to have everyone with us today. I will note, I know all three of these speakers quite well, and I probably will refer to them by their first names because we're comfortable and we hope to have a conversation with that together. But I don't want to in any way minimize the expertise that each of them brings today in this way. I'm going to ask each of you to start off with summarizing what you would like to share in terms of the type of COVID-related work that you've been engaged with as we've been through this year together, and some of the lessons you're starting to take from that as a result. We'll start with Dr. Massey. And Dr. Massey, as an infectious diseases doctor who's been at the initial epicenter of the epicenter in the United States at Elmhurst Hospital in Queens and New York, can you share with us a little bit about what you and your colleagues experienced in Queens and some of the major lessons that I've learned from that? And of course, I'd love if you have a chance too to add some of how our collaborative research effort has tried to move some of those lessons forward as well.
Sure, thanks, Rachel. At Elmhurst, of course, we saw a very, very rapid surge of patients in the spring, in March and April, with COVID-19, and we were quickly overwhelmed in terms of our usual facilities, our procedures, and our staff. We had to create new spaces for patients. We had to provide additional staff, often repurposed from our own people, but quickly from volunteers from all over the country, including all 4 branches of the military who came to help us. Our emergency department cared for a huge number of patients on their own for weeks at a time when there was no room in the rest of the hospital for them. Our intensive care units had to be expanded to cover maybe 5 times as many patients as they normally did. And many barriers had to be created within the hospital, that's physical barriers, and redesigned features had to be quickly assembled in the hospital to provide safe accommodations for these patients. Our outpatient services had to be closed, and our outpatient staff were brought to inpatient units. The surge so heavily focused on one hospital in Queens, reflecting the sort of disparity in where hospitals are and in terms of the populations that they serve. Queens is a borough with 2 million people. We're the only level 1 trauma center in our half of Queens. And as a result of that, we became a focal point for this surge that occurred in the spring. Our understanding of COVID-19 grew from that experience. We certainly learned some strategies that seem to work better than other strategies. Proning, for example, to prevent having to place patients on ventilators and to speed their recovery. We also learned about providing emotional support for our staff, particularly for our trainees. Everybody was really quite traumatized by that experience. And we still see the aftermath of that as we head into what hopefully won't be as big a surge now. And of course, the impact on our patients has been quite significant. We had a huge clinic population. Their care had to be interrupted, turned into televisits. And obviously now we want to be sure that everybody's care was resumed. And right now we've learned within the city hospital system in New York to have a level loading process. There are 11 city hospitals in New York, and we every day are transferring patients in and out in order to be sure that no one hospital has experienced quite the overwhelming surge. So we learned a lot. I don't think any of us ever, I know none of us ever saw anything like this before, and hopefully we'll never see anything like it again, but much of the country has gone through similar surges now. And hopefully we have some lessons that we can, share with them. In terms of the Cure 19 project, that's been really great. We've partnered, as you said, with the Arnold Institute in creating a partnership between Sinai and Elmhurst and Queens hospitals in order to foster collaboration in a number of different ways, research projects in particular, but also just sharing experiences and learning from each other, learning about each other. And that's one thing that, and I think one thing we learned, seem to have to learn over and over again, that this partnering of staffs and facilities is crucially important during times of crisis like this. And I guess we could talk about it later, but the independence of private hospitals in the country, the United States, usually stands as an impediment to that sort of cooperation. So it's been great having this collaboration with the Arnold Institute. We look forward to it continuing now.
Dr. Gardner, let's shift to you. And thank you, Joe. I really appreciate those comments. So Dr. Gardner, can you share with us a bit about the global partnership that Indiana University holds with partners in Kenya, where you work, and both how COVID has impacted the people of Western Kenya, and at the same time, how your long-term global experiences have really influenced things like the contact tracing effort at Indiana University and the work that you've been doing during the pandemic in that way.
Thanks, Rachel, and thanks so much for the opportunity to be here today. So, as you've already pointed out, and as I know you're well aware, the academic model providing access to healthcare is a 32-year-old partnership between Moy University, Moy Teaching and Referral Hospital, and a group of academic health centers in high-income countries that we collectively refer to as the AMPATH Consortium. The partnership's led by Indiana University, but includes 11 other North American institutions, including Mount Sinai, obviously, and who's heavily engaged in this partnership. And really, the mission spans across the tripartite mission: partnering in healthcare delivery and strengthening the public sector health system, strengthening and developing human capacity through training and education, advancing research to improve the health of underserved populations, and ultimately improving access to high quality medical care and reducing health disparities. So, as you said, I think we've been involved with COVID response sort of remotely through our colleagues in Kenya, and also sort of more locally in terms of the supporting the university's efforts, and really part of the state's efforts overall, because Indiana University, as you know, is a fairly large institution with 120,000 sort of constituents, including the student, staff, and faculty across 9 campuses across the state. So, I think just to maybe just focus on Kenya first, I think that, East Africa was sort of late to the COVID game in a good way, in the sense that there were, the first cases weren't identified until March, mid-March, and it allowed East Africa to sort of get an early jump on some of these mitigation and travel restrictions. And I think they fairly effectively, implemented those things. They also did a lot of other things really well. They rapidly retooled the regional HIV laboratories into COVID diagnostic centers. So all these PCR platforms became immediate COVID, testing capacity. Global funds were redirected towards COVID, and more locally at the hospital in Eldoret, they developed a COVID task force, which I was a part of, and training and preparation. Immediately stopped people from coming into the hospital and screening people upon arrival. And established a home-based care effort for people that didn't require admission. But as much of the world, they tired of those interventions. People sort of had fatigue. Interestingly enough, the initial testing followed the initial sort of cases within Kenya sort of followed the same pattern as HIV in the sense that it was really the truck drivers at border crossings that became the initial sort of, transmitters, if you will, or at least the ones that were identified across the country. So, in April, May, June, those things were relatively okay. And then really in August, Kenya opened up international flights again, in large part because they're sort of beginning to feel the economic consequences of their reliance on tourism. And we just saw the curve, sort of continue to sort of, bend as we've become used to in terms of these surges. Mid-October, restrictions eased once again, and sort of again, another sort of, steep increase in cases. So, we've been involved in a number of different ways in supporting our Kenyan colleagues. We do have Indiana University faculty there on site, but much of the work that we do in partnership with Kenyan colleagues is really about strengthening the health systems there and empowering our Kenyan colleagues. So not absolutely critical to have North Americans there, although often helpful to our partnership. But we were able to provide supplies, access additional PPE, testing commodities, nasal swabs, some clinical equipment, pulse oximeters, and UV machines to try and decontaminate N95 masks so they can be reused, things like that. We did a lot of supporting of the workforce through training, virtual trainings through a number of institutions in the NAPATH consortium, working with Kenyan colleagues, and trying to do a little bit more to understand the impact on service delivery locally, which obviously is another big topic that we'll probably touch on. But to do that, we had to sort of raise additional philanthropic funds on this side and try to redirect existing grant funds and things to where the need was. On the Indiana side, I think what became fairly, well, let me back up a little bit. So you have to understand the context. So Indiana ranks, I think, 47th in the union in public health infrastructure. And when, the CARES Act was passed, Indiana took that money as a state and invested it in a centralized contact tracing effort at the state level. Even though the legal authority to do contact tracing really remains with the local health departments, it was sort of taken up to the state level, in part just because they recognized that the capacity didn't exist at the local level to do this contact tracing. So there was this large team of phone-based contact tracers that was established at the state level. But I think we immediately recognized that we had an opportunity to bolster that effort with a contact tracing operation at the university level to take advantage of the information that we have as a university, which includes the dorms that people live in and the sports teams they're on and the activities they're part of, and those types of details that wouldn't necessarily be available at a state level, those kind of connections that are so important to tracking transmission, but that aren't available necessarily to someone who's picking up the phone at the state level. And so, in many ways, I think that the roadmap to our COVID response paralleled our HIV response, right? So we had, mitigation, obviously a lot of prevention activities. We have rapidly over the months brought up testing, both symptomatic and sort of mitigation or surveillance testing, which sort of parallels, again, voluntary HIV counseling and testing and opting out counseling and testing. Obviously the contact tracing to support effective quarantine and isolation, and then an outbreak response for sort of key populations or places where we're seeing sort of breakthrough, and ultimately vaccine, vaccine delivery. So, just to narrow down a little bit more on the contact tracing effort, and I think, the parallels are pretty clear, hiring and training a workforce, writing a script, building electronic systems to track interactions, working with local and state health departments, and ultimately, taking advantage of these university infrastructures to trigger, facility cleaning and those types of things that existed already, utilizing in our case, it was a Salesforce platform for the electronic system. So, all those things have parallels in our HIV response. And I think, in many ways, we were well positioned from our experience there to sort of implement something similar here to support the university and ultimately the state's efforts. But I'll pause there and see if we can.
Yeah, that's terrific. I think it is so interesting to consider too the ways in which, just as you're saying, whether it's you know, in how in certain ways the more robust public health responses of places like Kenya, and where we've worked, and how things have been built up over time with in order to combat the HIV epidemic, and then how powerful it is to move those lessons to places in the United States like Indiana that have really under-resourced public health systems, and how quickly that crumbles in that way when in the face of a terrible virus like this in that way. So Dr. Ballard, I want to also hear from you. So, you know, considering from your position as the executive director of the Community Health Impact Coalition, how have your coalition members been impacted by COVID, of course, and especially as we, you know, consider these questions of pandemic preparedness, what does this look like for community health workers in, you know, in these global settings, in many low-income countries and other settings, and as we think about how to best both support them currently as well as preparing for a new pandemic?
Sure, Rachel. And just again, thanks for the opportunity to be on this panel with Dr. Masci and Dr. Gardner. Very nice to meet both of you. We don't know each other as well, but it's been wonderful to hear about your work. So as Rachel mentioned, the coalition is really a team of health practitioners in 30 countries who've kind of come together to accelerate the adoption of high impact community health systems design. And so what that looks like is doing research across multiple countries together on practices that lead to quality of care, accompanying partners to adopt those practices. So a lot of knowledge translation work. And what it's looked like for a lot of 2020 is kind of treating this crisis as an opportunity to advance CHW professionalization and support for these workers. And effectively during the coalition, what we've done is we've played a role in kind of mobilizing hundreds of partners around the world to aggregate research, to rapidly produce and disseminate white papers and protocols on the roles and needs of CHWs in the response, and then pool resources for both the quantification and procurement of essential supplies, particularly PPE, as Dr. Gardner mentioned. And most recently, that's involved working with UNICEF and WHO on the soon to be released, I'm assured, guidance for the roles of community health workers in vaccine distribution, which is already late, but certainly continues to be relevant given the very slow distribution of the vaccine in almost every single country in the world except for Israel. This has been a really difficult year for everybody, for all patients, for all health workers, for all patients in waiting. What this has looked like, particularly for community health workers, is as the health cadre with probably the least job security and most precarity of many, in the sense that, particularly compared to doctors and nurses, they're the least likely to be paid globally, least likely to be accredited globally, the least likely to have ongoing training opportunities, to be in stock. There's a paper in press right now that suggests that in many places they're out of stock of essential commodities that they use to treat malaria, pneumonia, diarrhea up to half the time. That has, that all gets worse during a crisis. And that's particularly difficult because, as we know from Ebola, as we know from several recent pandemics, that often, and Dr. Masci sort of foreshadowed this, that a lot of times more people die from lack of essential health services than from the pandemic itself. And in places like Liberia, where I worked, where a really sizable number of consultations are actually done at community level, up to 1/5, up to 1/3 in some areas. The fact that you have a place, many countries where these health workers are not even necessarily, as I said, registered or counted, makes them suddenly very difficult to include in PPE projections, which makes it, again, impossible for them to carry out their work. They're left in this impossible situations where countries are either telling them to stay home, basically cutting off, primary health care at the knees, or continue your work without protection, putting themselves at risk, their families, and their patients. I mean, if you think about a person going door to door, you're basically turning a healthcare worker into a disease vector. And what we've seen throughout the pandemic, and still now today, is an absolute shortage of PPE. Right now, it's particularly gloves, inequity in PPE access, that richer countries were kind of gobbling it up, And then because of the historically more sort of marginalized position of these health workers, often exclusion of CHWs from national projections for PPE when countries were trying to do central planning, or even if they did do that planning and they were included, they were often the last to get that protection, even though, again, we all know that protection should be allocated based on the services provided, not the type of service provider. But that's not what we were seeing. And so a big part of our work has been to quantify that, to try to set up a mechanism to proactively favor that cadre. And we've actually seen, we have a paper that's looking at sort of the numbers from March to September now. And we see that in places where CHWs kind of were equipped with training and PPE right away, you actually didn't see declines in essential services that we have been reported, again, so far, quite massive declines. In terms of the next pandemic, we published something in BMJ Global Health in March, about sort of priorities for the response. And we said, we need to protect health workers, we need to interrupt the transmission of the virus, we need to maintain existing health services, and we need to shield the most vulnerable. And what's been interesting is kind of PPE emerged as a bottleneck for all of that, because without it, again, health workers in general can neither interrupt the virus, nor maintain health services, nor provide social services in the community. And I think what's really devastating is this whole story of PPE that we witnessed over the past year is now playing out in almost precisely the same pattern with the vaccine. There's an absolute shortage, there's inequity in access, and again, community health workers, despite being essential health workers, are not being included, again, despite WHO recommendations and not others, as part of that prioritized group in many countries. As of Martin Luther King Day, there were 25 doses of the vaccine that had been given out. In low and middle income countries, Mount Sinai does more than that in probably 10 minutes. Yeah, there's certainly lots to work on, and I look forward to the discussion sort of where we can flesh out some of these themes.
Yeah. First, let me mention, thank you so much, Madeleine. That was really, really helpful. And I think such an important perspective globally in terms of what's happening. I wanted to mention to the group that is connected with us today that we do have a question, and you're welcome to submit questions for our panelists today through the chat box. We'd love to have you write those, and we'll have some time at the end to look to those questions. So please feel free to type questions in the chat box, and we'd like to try to address some of those. So I would really like to talk more about this PPE issue, actually, and I think you did a great job of really setting up the global issues, and especially kind of this dual role of the importance of being counted and of being included in projections in this way across a workforce. And as you said, like what has continued to rise up as this huge priority of not having enough PPE. And I heard you mention that, Adrian. I know it's definitely something, Joe, that we, especially in those first months in New York, I know was the daily crisis of whether there was PPE for healthcare workers as well in this way. And I find it so. Personally, I find it so incredibly frustrating and makes me feel crazy that we are still so much in this situation a year in, that we have somehow still not managed to solve this, what seems to me, like compared to, say, questions of vaccine distribution, which are also, of course, a massive issue, but I recognize there's a greater complexity in terms of, manufacturing them and storing them and how they get transported. In contrast, PPE, it seems to my naive view, like it should be easier. Like we should be able to fix PPE. We should be able to make it, to distribute it, to make it available, and so at least to healthcare workers, if not broadly across populations as well. But I, of course, am very aware that no matter how I feel about that, that is not the reality. Could you maybe talk a little bit more about that? Really, any of you, but Madeleine, Adrian, and so on. But in terms of how I think you've started to explain, why it is, of course, such a critical priority in terms of not transmitting the infection forward, and of course, the key issue of protecting healthcare workers as well. But, what have we learned about why PPE is not accessible? Is it just a money issue? Is it a systems issue? Is it transportation? Is it all of the above? Is it government priority setting? Not being prepared in advance? I'm just curious, like, what have we figured out about PPE? Like, how could we possibly be in a better place, not only for our next year moving forward, but for another pandemic that might be down the road as well?
Well, let me just start on that one. I think what we discovered quickly was that most PPE is not manufactured in the United States. So the supplies from the countries that do manufacture it, specifically China, were difficult at first, and the quality of the PPE was not always really even understandable, let alone clearly sufficient. So I think that is a big lesson of this, that we have to have local sources, at least national sources, of PPE if we expect to be able to move ahead quickly if there's another pandemic that affects the United States the way this one did. And I think what we saw at Elmhurst, at least initially, with all the people that we imported from all over the place to help us, where people were improvising PPE, they were coming in with their own PPE that wasn't necessarily good for this. We saw lots of boots and crazy hoods and helmets that did not matter for COVID. And I think that's something that should be something we could standardize. And I think obviously, we had to start reusing N95 masks, reprocessing them, and that was a novel approach for us. It seemed in retrospect sort of ridiculous that we had to be thrust into that situation. Luckily, we did not have many infections among employees, despite all of that. But that does not guarantee that they won't start happening with the next surge.
Mm-hmm. Madeleine, yeah, go ahead. Sorry.
I would just add that to Dr. Masci's point, like the sheer quantities, and we did a quantification earlier this year, and if you were looking at even just this one cadre, community health workers across sub-Saharan Africa, 24 countries, to provide a year of protection, you were looking at 900 million masks, 15 million pairs of gloves, 18 million face shields, and that outlay, again, the prices were fluctuating so wildly because of scarcity that could have been $100 million, that could have been up to $500 million. And to put in perspective, Dr. Gardner was talking about raising philanthropic funds. That's like 20% of all the philanthropic funds spent annually on everything having to do with community health provision in the world, and you want to spend them on PPE that you can't get. So A, we don't have domestic manufacturing, but B, even if we do have it, and again, some countries like Ethiopia, Kenya, there is some happening. It is not happening at like China quantities, which is the quantities that we need. Thank goodness for the World Food Program and others that made transportation available for free and whatnot, but there wasn't enough, not to mention the fact that actually a lot of a lot of freight actually gets transported on empty commercial flights, which of course were then all canceled. Like, it was a perfect storm of a lot of different things. But I do think yes, this idea of having stockpiles, a lot of countries had stockpiles, but of course they were all expired. Like, it's the classic story of everyone likes to invest in emergency preparedness for about 18 months after the last emergency, and then it just slides down the list of priorities, which is insane because, we had been writing for the last decade about something's going to come and it's going to be contagious like SARS and it's going to kill like Ebola and it's overdue, and it was, and it did, and we almost every country in the world was caught completely unprepared. I am surprised and disappointed, though, to your point, Rachel, that there was a lot of talk about market shaping at the beginning of this pandemic in March 2020, and to be here and still have these shortages, and particularly this glove shortage, is disappointing and surprising, but a lot of it does have to do with that concentration. You have a COVID outbreak in one factory in Indonesia, and suddenly the world supply goes down by 10%. I mean, it's that concentrated.
Yeah, Yeah, absolutely.
I would just add, Rachel, I mean, I think, echo similar sentiments. Our colleagues in Kenya certainly struggled with sort of price fluctuations, rapid price fluctations, and shortages and quality, issues with quality of the masks and, disintegrating in your hands and this kind of thing. And, I think maybe it's obvious, but just to sort of emphasize the implications of that is both the lack of PPE and the lack of sort of basic infection control, policies and procedures in a lot of facilities in sub-Saharan Africa, end up make it really undermine the ability for healthcare workers to do their jobs, right, in the hospital as well as in the community. In Kenya, there have been, documented at least over 35, deaths of medical doctors, which it doesn't sound like much, but in a country like Kenya, that, it is pretty significant. It's a major, leaders really, arguably the most skilled plastic surgeon in Western Kenya, who's a faculty member at our Moi University partnership, lost his life to COVID. And, these will have ramifications for years to come in terms of the quality of the services that are offered moving forward. So,
yeah, it's definitely an issue with impact on so very many levels that way, like for the workforce, for their patients, for the future ability to, to teach, to build health systems, to move things forward in that way as well. Absolutely. I'd like to talk, you mentioned Ebola briefly in that, Madeleine, and I know, both, with work in Liberia that you've done, and Dr. Massey, of course, you're known for your Ebola expertise as well. I think it might be helpful to spend a little bit of time thinking about the lessons we did not learn from Ebola outbreaks and how we see that moving forward, and perhaps, could we still learn both from Ebola and also, as from the midst of this pandemic, what we can do better in that way as well. Sort of this, I think both the questions of kind of what worked for Ebola that we're not doing effectively now, but also, things that we, could have learned how to do and also have missed and so on. Be curious about thoughts from Ebola.
I can share two to start us off. One, I think it's our health system is only as strong as our neighbor's health system. That's the lesson from Ebola. That's the lesson from COVID. And yet we still see articles today, now in January 2021, about we have to vaccinate everybody in the United States first, as if that makes a darn bit of difference, or as if that is actually not going to cost the global economy more, cost the globe more in terms of lives lost by not prioritizing based on who is most vulnerable. So anyway, that's one. And then I think the second one is that robust primary healthcare systems and disease surveillance systems save lives. And if there was a community health worker in Gwekadu and someone starts bleeding from their eyes and they're linked up with the primary healthcare system, that's a much different story in terms of referral and rapid disease identification than the story that actually did transpire, which is where it spread uncontrolled for quite a while before it was actually ever even identified in this most recent outbreak in 2014, 2013, 14, 15 in West Africa. So that's where I'd start, but I'll pass to the real expert.
I think that those are such important points, Madeleine. I think especially, considering that not only do viruses not respect geographical borders, but this idea that that all of our strength needs to be focused with one nation, and that it doesn't, not only as an equity and justice issue, but also just even as a purely pragmatic issue, that's not how we actually make ourselves safer and healthier in these ways as well. Joe, thoughts from?
Yeah, I think, one thing that we have to contrast Ebola and COVID on is how outbreaks come in different shapes and sizes. And Ebola was pretty much confined to West Africa. There were cases that were transferred to Europe and the United States. There was transmission within the United States to 2 nurses. But what came out of that experience for our healthcare system was NETEC and the creation of Ebola units in 10 centers across the country. And those 10 centers have 20 to 30 beds total. So they really did not tool up for anything that was actually going to come here in any significant numbers. And I think the lessons learned from that, there was a lot of important information that was gleaned from that. What can we do to help out with a future Ebola outbreak, which was always going to be in Africa and was never likely to be widely transmissible anywhere else. And we learned some lessons from that, but they're not applicable very much to COVID, which is obviously something we're inundated with. And unfortunately, what we learned in a small sense with Ebola, the need for appropriate PPE, for training of staff, for understanding of transmission patterns, for removal of waste, et cetera, did not equally apply to COVID. And I've been involved in a couple of postmortems on Ebola, and looking at the next outbreak. This was before COVID. What do we do to prepare for that next one? When we sort of drifted into what if it happens here in the United States? What if we are the epicenter? And again, to return to a point I made earlier, we don't have a very unified healthcare system in the United States. We don't bring together resources that could easily, or even not so easily, address a wide-scale outbreak of something like Ebola. And we've learned that now with COVID-19, that there is something that needs to be fixed, and it needs to be fixed quickly, because the next pandemic or epidemic or local outbreak is coming. There's no doubt about that. There have been 3 coronavirus outbreaks in the past 20 years in the world, with none before that. So something like this, or something a little bit different from this, we have to have obviously what's called the all hazards approach, and have a style that allows us to quickly manipulate what we can offer in terms of care, protection of staff, protection of the community. And we're not near having that. And hopefully we will learn from lessons from this experience. But I think, as Madeleine said, the typical time frame of learning is less than 2 years after an experience like this. So hopefully it'll be different this time. But we have to keep on top of that issue. We can't just forget this once it's under control with the vaccine or whatever brings it under control. This was a horrible experience, and it's going to happen again.
Yeah, and it's interesting reflecting on. There's a 2015 perspective article from Bill Gates in the New England Journal, and then again another one in 2018, sort of lessons learned from Ebola, where he very clearly outlines what we need to be doing as a global community. Both in terms of setting up surveillance and early detection and a coordinated rapid global response, investments in research and development to have clear regulatory pathways to sort of scale up. But also emphasizes, I think, to Madeleine's point, just the strengthening of health systems and primary healthcare systems, and I think this is one of the lessons from Ebola as well. It's one thing to talk about a sort of pandemic response, but if no one goes to the health center when they have a fever because they don't expect anyone to be there and there's no service there to count on, and there's no trust in the system, then you've lost the battle before you start, and you can invest in sort of fancy surveillance systems, but you've got to have that initial sort of trust in the primary healthcare system, and then the laboratory ability to, and the just basic equipment to sort of make, the diagnosis, right? If, you show up to the health center, you can't check if there's a fever, or you can't check a blood culture to look for more routine pathogens, then, again, you're way behind. So it's just interesting reflecting on those things and how, we frankly didn't learn from those lessons and put things in place that need to be. But, I think it's clear, it's going to take a lot of political will at a global level, and, whether we can do that. But
yeah, absolutely. I am very conscious as we're, thinking about this and talking today, all 3 of us are coming from a North American perspective on this, despite our global connections. We have some of our global partners that will be talking a bit later as well. But the role, I'm struck by thinking about the roles of both misinformation, the ways in which kind of scary ideas or conspiracies and things spread in both pandemics in different ways, as well as the permutations of systemic racism that enter into that, especially from a white North American perspective in this way. In that, I think we heard a lot of often during the the Ebola pandemic within the United States, at least, there were a lot of kind of these, giant fears, very disproportionate to reality about the chance that, this scary disease that I think we were really viewing with a very, truly a very racist mindset towards it. Not at all to minimize how terrible Ebola is, of course, but that it was seen as this somehow very immediate threat, no matter where you were in the United States and so on, compared to the misinformation and where you see fears and threats of this, how, white America is responding in many ways to this virus that's actually here in the United States. And that is, in fact, a significant threat. I think that becomes another layer of our preparedness as we continue to think about, how do we better communicate? How do we combat misinformation and this, what's, been called this infodemic of incorrect, false things, of conspiracies, of the ways that information and science become politicized and undermined in different ways and things too. So it's interesting to view, when I think about Ebola and those from the US in terms of considering the response to how that was considered, I think it's so important to have some of those items come into play as well. I see there's a question that was written in from the group related to thinking about those who are what we often are referring to as COVID long haulers, people who are continuing to have longer term impacts over time from COVID, which we've been increasingly seeing can be extremely debilitating and really cause long-term challenges. And wondering how that might impact the healthcare system in the future. And with that, the question asks, is this something that's being discussed globally, specifically in low and middle income countries, and how we might consider provisions for longer term care and care for those who are struggling with the long haul COVID issues as they're described. I wondered if anyone has heard, seen, thoughts about that and the longer term impacts of COVID as well globally.
Yeah, I mean, it's interesting. I would say I haven't heard a lot from our Kenyan colleagues about this topic, and I wonder. Clearly, part of it is under recognition, and in some cases, so that the resilience of the people there, and sort of some of these symptoms that are just sort of taken for granted as part of life, and not necessarily seeking out, but it's interesting. I mean, the clinical manifestations in Kenya, at a population level, have been quite dramatically different, right? Whether that's related to lots of theories about sort of coronavirus immunity across immunity, or other sort of infectious or immunologic differences, but we haven't heard much about this. But I suspect we will. Just as we will see more and more impact on programming. There are estimates on about the impact on other health systems and the delivery of NCD care and HIV care, and the additional deaths we should frankly expect from TB, malaria, and HIV alone in the coming years from the impact of this. But I think, again, it's interesting. We haven't seen a lot of the sort of people coming with long hauler kind of syndromes, but expect we will over time.
Yeah, I would say that we're beginning to recognize what's been described in the China data, that there are a lot of long hauler symptoms, and we've tried to provide at least the beginnings of services for following this, whether we're dealing with 9/11 sort of problems that are going to persist over decades, or whether we're dealing with short-term problems that are going to resolve with time. We really don't know yet. So we're obviously launching pilots in various ways, looking at the pulmonary disease, the heart disease that comes from this. This is one of the really insidious qualities of COVID-19, that it has not only this immediate and life-threatening component to it, but it has a long-lasting component in multiple end organ sites that we're just beginning to really fully recognize. It's hard to do all of this while you're still getting inundated with the acute cases, but I think we're going to be certainly living with the aftermath of COVID, regardless of vaccine success, for years.
Dr. Ballard, it strikes me too that there would be a critical role for a community health oriented workforce in this over the long term as well. Are the organizations that you work with starting to either see this or consider this? I recognize there are many other immediate challenges as we've said as well. And I think it is something over time we'll have a better sense of too.
Yeah, it's interesting. I think we've seen a couple of countries, even in this acute phase, invest more in home-based care, including Kenya. Actually, there's a national policy of home-based care. In Uganda, they reoriented about a month or two ago their COVID response, just because what they were doing were, again, bringing all these COVID patients to hospitals and clinics, and of course, there weren't enough beds, and what to do with those that weren't as serious. And what they did is they activated these networks to provide, again, social solidarity in the form of food or symptom monitoring, et cetera. So I think actually the infrastructure, because of things like HIV, AIDS, because of things like a critical, human resources for health shortage that was worsening already before the pandemic, and is only, I think it was estimated to be 18 million shortage of doctors and nurses by 2030. I can only imagine what that number is at this point, with all these interruptions, both education and healthcare worker deaths. Anyways, but as a consequence, they have a lot to teach, I think, higher income countries about what can be robustly managed at the community, in what ways actually that is standard of care. And I think we've already seen that it's standard of care for a lot of chronic conditions, HIV now among them, to preventative care, weight loss, all these types of things that people are struggling with in low and middle income countries, but high income countries too. So I would agree with Dr. Gardner. I don't think that's role has been really well defined in terms of long COVID, but I expect that it probably will be, and that this will be a component of it.
Mm-hmm. There's a question from the Q&A box that I think actually ties into what you're saying in a way, in terms of how well we've seen many of our global partners deal with particular health challenges at a community level, and even with limited resources. The question is, to what extent can low and middle income countries secure a more prominent role in global response to the next pandemic and fairer sharing of resources by demonstrating how well they adapted limited existing infrastructure to respond to this one? Would any of you like to comment on that, or thoughts around how they might be able to have more leadership roles, and in that way as well a fairer, kind of more equitable distribution of the resources needed for addressing pandemics as well?
Again, I think there'll be postmortems on COVID, like there were postmortems on Ebola, and one of the things the postmortems will show is what Dr. Masci's been saying for this entire hour, is that in most countries, the primary provider of healthcare is government. It's not the private sector as it is here in the United States, and that has big advantages in terms of coordination, in times of crisis, in terms of command and control, in terms of sharing of resources and information. And I think we've seen the role of regional bodies like Africa CDC, and we've seen the role of strong federal governments, even in decentralized systems like in Kenya. Just the coordination is way better, and there has to be, I think, as the United States, as the new administration coming in now in the United States has acknowledged, like some federal response and some federal coordination. But again, that is difficult if there's, if it's that's you don't have willing participants. So I think the idea of having collaborations that exist prior to emergencies and is going to be critical, whether that's on disease surveillance, whether that's on emergency preparedness, whether that's on electronic health records. Like, I think there's a lot of ways in which diverse systems within systems can collaborate, and I think that's what I've seen, and that's tough to sort of prove empirically. But even in places where folks were collaborating on something totally different, it's a lot easier to then pivot to collaborating on a response than having to even figure out, oh gosh, who are the stakeholders? Can we bring them around the table? Do they trust each other? What's going on? They're all competing. The incentives are totally misaligned. So yeah, I think some focus on that more broadly, and there are many opportunities would certainly help.
I think it's interesting, actually was thinking about this earlier with our group here today, even that each of you are parts of organizations and collaborative partnerships that really do emphasize the incredible mutual benefits that are there when we collaborate in these deep long-term ways, that when you form coalitions, when you form long-term partnerships between academic medical institutions and hospital systems, when you're not only thinking at a health systems level, but also really committing to being in partnership, across these different challenges, I believe this quite passionately, of course, but that really does move forward and make possible gains that are, I would say, not just additive to each other, but synergistic in these ways. And perhaps that never is more critical than when you are in crises like this, where, as you said, it's not having to start from like, who could even partner with us in this, but to build on those existing collaborations, to advocate together for what's needed, to look at data across systems, as rapidly as possible, and then even thinking towards more sustained responses and government and global groups in that way, how things can be moved forward more effectively. I am mindful of our time together, and we're excited. We have our next session in the symposium will be starting at the beginning of the hour with Lori Garrett and Dr. Daniel Lucy, who are really excited to hear from as well. I wanted to just open it for a final comment or two from each of you related to this ongoing question of when you think about our global collaborations, our lessons learned in this pandemic, what can we think about, or where do you place either your hope or priority for considerations for our next pandemics globally as well? Adrian, should we start with you?
Sure.
Dr. Gardner?
Yeah, I think we've touched on it already. I think really is, obviously we can take advantage of the existing relationships that we have, but we need to build sort of still, better sort of double down on global leadership at sort of national levels in terms of building the systems that can respond to these sort of emergencies in an albeit a siloed way, but those have to complement the sort of existing longer term health system strengthening agenda that has to continue and also be scaled up and recognized as part of the essential preparation really for these types of pandemics, and that includes addressing basic infrastructure, but also things like climate change and understanding how that factors into more and more of, as Dr. Massey said. I mean, there's we've had 3 of these outbreaks in the last 20 years. Why is that? What's going on here? Why are we having? It's only going to pick up, right? And so those sort of more global issues that just need better global cooperation, which is easier said than done, obviously. But
Dr. Ballard, you want to give your sort of closing thoughts on this?
Yeah, I think we need to figure out how to make a more compelling case to the public, to nation states, to both engage in and fund collaboration. I mean, if we look at the ACT Accelerator, which is the body that's aimed at providing pandemic resources to developing countries, they are facing still a $27 billion funding gap. Which sounds like a lot of money until you open the New York Times yesterday and you see that, by monopolizing the vaccines for COVID-19, we could, there'll be, global economic devastation that will hit affluent countries as well, to the tune of, I think it was $9 trillion. And so the problem is these costs, much like the costs of climate change, are distributed, they're murky, they're in the future, there's no accountability. And so I think we need to think really long and hard about how do we make those costs real, immediate, assigned, and therefore avoid them in the future.
Great. Thank you so much. And thank you so much to both of you for your time today. I'm going to turn to Dr. Massey for his last comments, and also he'll be bringing us into the next session as well. So we'll transition with that.
Yeah, thanks, Rachel. I think it's hard to be optimistic about any of this. We have a world that is lots of different governments, lots of different leaders, lots of different orientation, lots of different economic situations, and even the United States. We have 50 different somewhat independent entities. It's easier to point out the problems and speculate on potential solutions than it is to actually come up with concrete steps toward a solution. How do we develop a true all hazards approach that could actually do better if we're faced with something like this again in the near future, which we will be? You know, right now it's not clear with the emerging strains of COVID, even before the vaccine rollout, whether the vaccine strategy is even going to be usable going forward. There's a lot of concern now that we may have to retool vaccines, retool the vaccine approach right in the middle of this. And, you know, for me, one lesson is you can't learn that much and do that much right in the middle of one of these. And the challenge is going to be maintaining genuine focus and genuine steps toward improvement in between these. And that is a challenge that I just don't see us coming up with an answer to confront right now.
Mm-hmm. Absolutely. Well, again, we appreciate everyone's perspective as we do that. I would note to everyone, I forgot to mention the recording of this session and the other recordings from our symposium today will be put on YouTube within about 24 hours. So feel free to refer to that, to send interested people to that as well. And again, we'll turn it over to Dr. Massey to move into our next hour, which is going to focus on what the world must learn with Lori Garrett and Dr. Danielle Lucy, who we're really excited to hear from as well. So thank you again so much, and thanks to our participants here.
Thank you.
Thank you.